Welcome to our journey into the fascinating world of gastrointestinal tract pathology. Pathology is simply the study of disease through scientific methods. It's the bridge between basic science and clinical medicine. To understand any disease, we follow four key principles. First, etiology. What is the cause? Is it genetic, like an inherited mutation, or environmental, like a virus or toxin? Second, pathogenesis, the pattern of cellular injury. This is the step-by-step story of how the initial cause leads to the disease. Third, morphology. The structural changes we can see either with the naked eye, that's gross morphology, or under the microscope, histopathology. And finally, clinical significance, how the disease manifests in a patient, the signs, symptoms, and its overall impact. Keep these four pillars in mind as we explore the diseases of the GIT, starting today with the oral cavity and salivary glands. The oral cavity is our gateway to the GI system. It's a complex environment, and it's susceptible to a wide range of disorders. Today, we'll cover some of the most important ones, from common developmental issues like cleft lip to painful ulcers, viral infections, and unfortunately, even cancer. Understanding these conditions gives us a fantastic foundation in applying those core principles of pathology we just discussed. Let's begin with cleft lip. We'll break it down using our four principles. Etiology. The cause is multifactorial, involving both genetic predispositions and environmental triggers like certain medications or deficiencies during pregnancy. Pathogenesis. The mechanism is a failure of fusion. The facial prominences, one from the superior, two from the sides, lateral and medial nasal, and two from the inferior, maxillary and mandibular. They do grow but fail to fuse together completely during early embryonic development. Morphology. The change is grossly visible. A full thickness defect in the lip, which can be unilateral or bilateral. It's often accompanied by a cleft palate. Clinical significance. This leads to significant challenges with feeding, speech development, and ear infections. It requires surgical correction and multidisciplinary care. Next, the common Aphthous ulcer. Etiology. The exact cause is idiopathic, unknown, but it's strongly associated with environmental, like food sensitivities and traumas, and immune factors like stress, hormonal changes. Pathogenesis. The trigger is thought to lead to a localized immune dysregulation, causing an inflammatory response that damages the mucosal epithelium, which present as ulcer. Morphology. We see a gross superficial ulcer with a characteristic grayish-yellow fibrin base surrounded by a halo of erythema redness. Clinical significance. It presents as a painful, recurrent shallow ulcer that heals spontaneously within 7 to 10 days. Treatment is focused on pain relief and reducing inflammation. Behçet syndrome is a systemic vasculitis affecting the entire body. Let's apply our framework. Etiology. The cause is unknown, idiopathic, but it's believed to be an autoimmune reaction potentially triggered by an infection in genetically susceptible individuals. Pathogenesis. The key mechanism is immune complex deposition, leading to a vasculitis, inflammation of small blood vessels throughout the body. Morphology. Recurrent, large Aphthous ulcers, genital ulcers, and skin lesions that take weeks to months to resolve are present. Histologically, we see neutrophilic infiltration and damage to blood vessel walls. Clinical significance. The classic triad is oral ulcers, genital ulcers, and uveitis, eye inflammation. It can also affect joints, the nervous system, and blood vessels. Management requires immunosuppression. Next disease is oral herpes, also known as oral herpes simplex or cold sores, is a common viral infection. It manifests as small painful blisters or sores that typically appear on or around the mouth. Let's apply our framework. Etiology: the cause is an environmental infectious viral agent, the herpes simplex virus type 1. Pathogenesis: the virus enters and causes a primary infection. It then travels to sensory nerve ganglia like the trigeminal and becomes dormant. Later reactivation by stress, sun, causes the virus to travel back down the nerve and infect epithelial cells. Morphology: grossly, we see clusters of small vesicles, blisters, that rupture to form painful, shallow ulcers. Histologically, we see epithelial cell damage with characteristic viral inclusion bodies. Clinical significance: presents as painful cold sores or fever blisters. It is recurrent and contagious. Antiviral drugs can reduce the duration and severity of outbreaks. Since oral herpes is spread through direct physical contact, the best method of prevention is to avoid physical contact with a person's herpes sores when they are having an outbreak. Now, the most serious oral disease, squamous cell carcinoma, or epidermoid carcinoma, comprises a number of different types of cancer cells that begin in squamous cells. Etiology: primarily environmental. Tobacco and alcohol are the major risk factors acting synergistically. HPV is an emerging cause for oropharyngeal cancer. Pathogenesis: carcinogens in tobacco and alcohol cause cumulative genetic damage and mutations in squamous cells, leading to uncontrolled growth from normal to cancerous epithelium. Morphology: leukoplakia, a white plaque that can't be scraped off, may show dysplasia, and erythroplakia, a red plaque highly likely to be dysplastic or cancerous, are the precursors of squamous cell carcinoma. Cancer: grossly an irregular ulcerated mass and histologically invasive nests of malignant squamous cells. Clinical significance: often presents as a non-healing ulcer or lump. Risk of spread to lymph nodes. Treatment involves surgery, radiation, and/or chemo. Prognosis depends on early detection. Now, let's apply the same framework to salivary gland diseases. We have three major salivary glands, each with unique features. Parotid gland, the largest gland located in front of the ear. It produces serous, watery secretions and is pierced by the facial nerve, an important clinical landmark during surgery or in parotid tumors. Submandibular gland, found beneath the mandible, it secretes mixed serous plus mucus fluid, making it prone to stone formation due to thicker saliva. Sublingual gland, the smallest, located under the tongue, primarily secretes mucus, giving viscous saliva that helps lubricate the oral cavity. Always remember the facial nerve passes through the parotid, making it key in diagnosis and surgery. Mumps, a classic viral sialadenitis, commonly affects children between the ages of 2 to 12 who haven't received the mumps vaccine. Etiology: an environmental infectious agent, the mumps virus. Pathogenesis: the virus is transmitted via droplets, replicates in the respiratory epithelium, and spreads hematogenously through the blood to infect the parotid glands and other organs. Morphology: grossly bilateral parotid swelling, chipmunk cheeks. Histologically, the gland shows edema and lymphocytic infiltration. Clinical significance: painful parotitis, fever. Can lead to complications like orchitis, risk of sterility, pancreatitis, and aseptic meningitis. Can be prevented by vaccination. Sialadenitis is the inflammation of the salivary glands, typically caused by obstruction by stone or bacterial infection. Etiology: the primary cause is environmental, an obstructing stone, sialolithiasis, and infection by bacteria and viruses which creates stagnation. Pathogenesis: duct obstruction which causes saliva stasis leading to secondary bacterial overgrowth, often Staphylococcus aureus, which results acute inflammatory response. Morphology: grossly, a painful, swollen and erythematous gland, usually unilateral, histologically neutrophilic infiltration and destruction of glandular tissue. Clinical significance: presents with acute pain, swelling and pus that may express from the duct, treated with antibiotics and stone removal. Next disease is pleomorphic adenoma, the most common benign tumor of parotid gland. Etiology: the cause is largely unknown, idiopathic, but certain genetic rearrangements are commonly involved. Pathogenesis: it arises from a proliferation of both ductal, epithelial and myoepithelial cells, which together produce a mixed stromal component, like cartilage. Morphology: grossly a firm, mobile, well-circumscribed mass. Histologically, a mixed appearance of epithelial cells and mesenchymal-like tissue like myxoid, chondroid. Clinical significance: presents as a slow-growing, painless mass. The main issues are a high recurrence rate due to microscopic extensions through its capsule and a small risk of malignant transformation into carcinoma. The second most common benign tumor is Warthin's tumor, commonly involved stroma and lymphoid of parotid gland. Etiology: strongly linked to environmental factor like smoking. Pathogenesis: thought to arise from salivary duct epithelium incorporated into lymph nodes within the parotid gland. Morphology: grossly a soft, cystic, often bilateral mass. Histologically, a double layer of oncocytic epithelial cells surrounding cystic spaces with a dense lymphoid stroma containing germinal centers. Clinical significance: presents as a slow-growing, painless mass. It is almost exclusively parotid, has almost no malignant potential, and is often bilateral. Finally, the most common malignant salivary gland tumor, Mucoepidermoid Carcinoma. Etiology: most cases are sporadic, idiopathic, though some are environmental linked to prior radiation exposure. Pathogenesis: it arises from the pluripotent reserve cells of the salivary duct, giving rise to a mixture of cell types. Morphology: grossly an ill-defined infiltrative mass. Histologically, a mixture of mucin-producing cells, squamous cells, and intermediate cells. Clinical significance: presents as a growing mass. Low-grade tumors have a good prognosis. High-grade tumors are aggressive, can cause facial nerve paralysis, and have potential to metastasize. We've used our 4 pillars of pathology to understand diseases from the common ulcer to significant tumors. Join us next time as we continue down the GI tract to explore esophageal diseases. If this structured approach helped you, please like this video and subscribe to the channel. Your support helps us create more content. Thanks for watching.